Great. Well, welcome everybody. Thank you so much for joining us. This is the first inaugural session of the Stanford Medicine Center for Improvement speaker series. We don't know exactly how this is going to evolve or what this will look like in the future, but we had a great pair of individuals who had a great topic, and we wanted to go ahead and get started. So that's what we're going to do. So just to give people a little bit of background about what we're thinking for this program, the concept is that we want to have a venue where people can come and share great ideas, learn from each other, and really chip in and have a lively discussion about the interesting topics of the day. And make sure that we have just a regular place for people to go and come participate in this forum to facilitate organizational learning. So some of the topics that we anticipate that we'll see, excuse me, at this forum will be like examples of what we have today, which is an innovative concept that we've really started growing locally, that we have people who are thinking about this, have done some work, and would like to share both to get some input and to have a discussion around, especially as it is a timely topic. So that's one example. I think this will be a really great example to start off on. Some other examples of the types of things that we would hope to see at this forum include what I would call a work in progress, where it's something that you or others are working on related to improvement, and you want to share it and get input from the community. So if you have an idea that you'd like to put out there that you'd like input on, let us know and we can put that, tee that up for this forum. Other examples that we can see is if you're going to a national presentation and you want to have a place to give your talk beforehand and get some input, then this is a place that you can come and share that. There also may be educational topics that we want everybody to learn from, or that we think is an opportunity that people will be broadly interested in. And if so, we would love to have this be a place that people could learn and discuss that. And then finally, if we have guest speakers, this could potentially be a great forum for people to come and plug in. So our concept is that this is, we kind of initially termed it a brown bag lunch, so to speak. I don't know if you have your brown bags, but we want it to be relatively informal. The content we think is going to be outstanding and innovative, but we don't want it to feel too much like grand rounds or too much like a lecture per se. So we'd like to have time for presentation and then lots of discussion. So we've asked, in this case, Margaret and Ron, who will be presenting to us, to keep their presentation to about half the time, and then we'd like the rest of that to be a conversation. So please do be prepared, take notes, think of the type of discussion you'd like to have, and let's make this a lively discussion after they present. So with that, I will go ahead and introduce our speakers, and we'll go ahead and get started. So first of all, Margaret Smith, who I think is widely known in this community, is currently the Director of Operations of the Stanford Healthcare AI Applied Research Team, or HART, where she works with industry partners, clinical operational leaders at Stanford on the application, development, implementation of AI technologies. So all of you know her broad expertise in quality improvement. She was a member of the quality improvement team for many years as one of the senior leaders of that program, and also has a wide breadth of experience outside of Stanford in quality improvement. She holds a bachelor's degree in finance and risk management, a master's in business administration, with a specialization in healthcare management from the Baylor Hankemer School of Business and Robbins Institute for Health Policy and Leadership, as well as a Lean Six Sigma Master Black Belt certification. So Margaret, welcome.
Thank you.
And Ron, who will be her co-presenter. Ron Lee, Dr. Ron Lee is a clinical assistant professor of medicine in the Division of Hospital Medicine and the Center for Biomedical Informatics Research at Stanford University School of Medicine. He's also the Medical Informatics Director for AI Clinical Integration at Stanford Healthcare, and he works around design, implementation, evaluation of novel systems of care delivery that can be enabled by artificial intelligence. As I think you'll see in his presentation, he has a strong background in data science, digital health, and information technology, as well as design thinking and process improvement. So we're going to see the intersection of those. Ron received his MD from Northwestern University Feinberg School of Medicine and completed his internal medicine residency and clinical informatics fellowship here at Stanford. So with that, we will turn it over to Margaret and Ron. Thanks so much for joining us.
Thank you so much. Really appreciate it, David. So I'll kick us off here. It's super excited to hear sort of your guys' long-term thinking around this talk, and we're absolutely honored to be the inaugural talk, be your guinea pigs. So we're really excited to be here, and I'm so happy to be joined by Dr. Ron Lee, as we've become very close colleagues over the last couple of years, working on a couple projects together. So excited to give this talk and then hopefully give it in other forums as well. So building AI and enabled systems for patient care. So quick context, and then sort of our goal today, which I'm glad sounds like is very in line. We're hoping it can sort of spur a lot of really good discussion, is Ron and I, among sort of many other projects that we've worked on in this space of sort of AI development and integration in healthcare, we've worked on two very special projects together, and they're special because they are two projects implementing AI-enabled solutions at Stanford Healthcare. And so we really wanted to highlight these two projects, which are ongoing work. And so we're excited to hear what people's thoughts are, even as things are being built as we're speaking. So our goal today is to really share our experience and what we've learned thus far from those projects. One is actually in pilot currently, and the second one is nearing pilot in sort of mid to late October, of sort of a first iteration of a pilot. And so want to share what we've learned thus far and discuss sort of how we feel like what we've learned can apply more broadly, and would really love to sort of have that be a dynamic discussion. And then hopefully what we can talk a lot about is share what we think is necessary and then discuss as a group to increase the capacity for AI development integration at Stanford. So how do we take sort of what we're learning with these two initial projects and then sort of force multiply that across the organization? So really, really excited to talk with everyone today. So as David mentioned, Ron has a really strong data science background, informatics background. And so what we thought would be super helpful, I think we're all probably operating off of different levels of knowledge of what is AI, what is machine learning. And so we thought we'd start with just a little bit of information about what is it, and then a little bit about why all the hype today. I feel like we're hearing a lot about it, not only in the news and sort of tech news, but also just in general, you're hearing a lot more about AI in healthcare. So why is that? So with that, I will pass it to Ron.
Sure, thanks, Margaret. And agree. I mean, this has been so fun and just interesting working with you and everyone else over the last year. I don't know if you remember how we met. But it was actually at a Team Steps, I think, conference. Yes. It might have been Alushka who actually introduced us because I had some question about something. I don't even remember what it was, but I think it's just a testament to the Stanford community. You just meet someone randomly at some noon conference or talk, and then something great happens afterwards. So this is just such a great experience. So one thing that we had wanted to start off discussing is just, as Margaret mentioned, how can we actually make AI useful? And one of the reasons why we're so excited to talk with this group is that this is not a technology group, right? I mean, we like technology, we're excited about technology, but ultimately our goal is to improve healthcare delivery at Stanford. And I'm sure many of you are familiar with the Gartner hype cycle. If you think about all these emerging technologies and they get hyped up, and then it's almost like this inevitable outcome that they fall into this so-called trough of disillusionment. And AI definitely is on the docket, kind of looking down this cliff. And people have talked about these terms, AI winters and so on. So yes, I think that is a concern, but I actually don't think it's inevitable. I think it actually is. It is that because we are in a healthcare system where our mission is to improve care delivery and not so much just thinking about the technology. I think that's why we can actually prevent AI from falling into this trough. And we'll talk about how we're thinking about this. Next slide. So as Margaret had mentioned, we wanted to just spend a couple of minutes reviewing what AI is exactly. And this may be a review for many on this call. But just because we hear all these terms, AI, machine learning, deep learning, et cetera, what is it? What is it and what exactly do we mean when we say those terms? And by the way, this is something that I believe, I think Nigam Shah is actually presenting something around this in more detail later on this year, and he's probably one of the best people to talk about this, but I'll give a very brief preview. So basically, when we think about AI or artificial intelligence, I mean, that's a pretty broad term, but we really think about these two specific things that, that models can perform artificially, which is to classify things or to predict things, predict data points in the future. So classification just means you have a bunch of data, a bunch of, you probably have seen these photos of animals, and then, or basically you have all these photos, and then the algorithm basically tells you if it's a cat or a dog, right? So that's a pretty classic AI classification task. Or you probably hear about these models predicting stock prices in the future, which we all know is very difficult, but that's an example of prediction where we're trying to predict a data point that doesn't exist yet, but may exist in the future based on past behavior. That's pretty much what it is. And then you basically try to extract the outcomes from these tasks to build complex systems. So if you think about a self-driving car, ultimately the AI in a self-driving car is doing hundreds of thousands, millions, if not tens of millions of classification and prediction tasks all the time. So they're classifying what the camera is looking at ahead of it. Is it a stop sign? Is it just a flower, right? And then you're predicting what the trajectory of the car will be, where it will be in the next minute if it goes at this speed. And that's basically what it is. Next slide. And then you hear about machine learning and deep learning or AI/ML. I think that's something that we say a lot. You know, what exactly is the difference between AI and machine learning? People probably have different interpretations of these terms. I mean, the way I like to think about it is that AI is a very broad term to describe anything that is somewhat intelligent, that can do classification, that can do prediction, but it could use anything as simple as a decision rule, like an if-then statement that you code in, or something as complex as a neural network. But then I think what really gets people excited about AI now is this branch of AI called machine learning, which is really a specific set of mathematical methods to perform classification and regression using a lot of data fairly accurately. Actually, it's not even that new. I mean, it's been around for quite a while. And then a subset of machine learning is deep learning. So that's a specific set of machine learning algorithms that allow you to predict things even more accurately. And you're not bound necessarily by, by assumptions of linearity and things like that. So this is kind of how I think about the different categories. And people often use machine learning, AI interchangeably. In this talk, we'll talk about machine learning when we refer to this specific model, but AI is a broader concept. Next slide. And just these are some of and you'll hear some terms like support vector machines, random forest, neural networks. So these are all algorithms that allow a computer to learn from data. So if you have a ton of data, 100,000 data points, and you're trying to make sense of what the relationships are between variables and outcomes, you can use a regression, which is actually a machine learning algorithm. You can use a support vector machine. And then on the very right, it's a neural network, which is what gets a lot of people excited. And then from these learning algorithms, you learn models, which are essentially representations of relationships that you assume are true, but may not necessarily be true. Like there are errors associated with every single model. Next slide. So this is actually a machine learning model. So I'm sure many of you have seen this before. This is a MELD score, which basically predicts mortality for patients who receive liver transplants. And what happened was, I think the people who developed this, they had a ton of data. I think they probably used some kind of linear learning algorithm, like a logistic regression or linear regression, to then learn this representation between, that represents the relationship between clinical parameters, like bilirubin and creatinine, with a person's risk of dying. And basically this is a model that we now use all the time in clinical medicine. Next slide. Okay, so clearly this is nothing new, right? I mean, machine learning, actually neural networks have been around for probably more than 70 years, 60, 70 years. Why all the hype now? And it really is just about data and computing power. So one of the, I would say, positive effects of the EHR or the High Tech Act. I mean, people like to, there are definitely a lot of things wrong with, I think, the government trying to make everyone install EHRs, but I think one of the things it did do was digitize a ton of data that used to be on paper. So we've never had this much digital data in healthcare ever, but now we do. So that basically makes all these things possible, because before we couldn't have, we got the best neural network structure, but you don't have any data, so you can't do anything with it, but now we do. And then we also have computing power, which is something that has been growing exponentially for a long time. We can argue it may not necessarily continue to grow exponentially, but it's something that we have that we did not have before. So those two things allow us to actually exercise some of the theories behind machine learning and actually build real models that classify and predict real outcomes in medicine. And then finally, the healthcare systems are more wired. So we have not just the EHR, but we actually have an entire environment of applications, digital technologies, storage, all sorts of things. And Stanford, among other hospital systems, are quite capable now of both developing and using artificial intelligence. Next slide. Next slide.
So building off of that, so it seems, as Ron has mentioned, that sort of our technical capacity and data availability seems it's ripe for machine learning to sort of transform the way we're delivering medicine. And yet, both Ron and I think one of the first conversations we had was about this, which was, why is there then this sort of continually growing body of literature sort of heralding the accuracy of novel models, whether it be prediction of readmissions, prediction of long length of stay, auto documentation, and just how accurate these models are. And yet we see very little sort of literature in the ROI that AI is creating in healthcare. And so on one of our projects, which we'll talk about shortly, we actually started with a broad literature review to understand what is currently being done out there. Many of this particular type of algorithm, have been created and published on, and yet we were hard pressed to find even one paper that spoke to a true implementation with long-term outcomes. And so I think there are many people asking this question, and why so many people think that perhaps there's impending doom for AI and that hype cycle is just going to slide right down. But I think, there are people on both sides of the issue asking the question, and both sides being clinicians and clinical operators, as well as those putting the time and the energy into developing machine learning models. So clinicians are saying, how is this going to affect me? How is this going to help me? And machine learning model developers are developing and seeing their models sit on the shelf. And so everyone is sort of curious to understand this. And so, as Ron and I have thought about it, and many others have sort of entered into this conversation, our hypothesis is that the answer is not a technical one, which actually you hear a lot about the technical barriers to AI, integrations and things. But that really the biggest hurdle is that we need an entirely different approach and mindset when it comes to how AI should be implemented and developed for healthcare. And that really what's needed is a paradigm shift from, okay, I have a machine learning model, it performs really, really well, now what? To, okay, I have this problem I need to solve, how can machine learning enable that solution? And in the first, outline there of, okay, I have machine learning, now what? It's really structured as a sort of compartmentalized sequential development of model, then implementation, versus this idea that you can do those things in parallel, and that we should be building systems and processes and methods around problem solving while in parallel developing and understanding how AI can enable the solution. And I think it starts with being able to see where AI can be helpful. And we'll talk more about that as well. So you might wonder sort of, how did we land here? How did we land in this idea that we need a paradigm shift? And it really starts back with something that gets talked about a lot in improvement, and that is that healthcare is a complex system. And by definition, meaning there are many subunits interacting on a daily basis, and it is those interactions that create the observable behavior and outcomes from that system. And that system is that set of agents sort of interacting with each other and developing the visible or invisible structures and patterns within a system. And there's so much that happens invisibly within healthcare. But I think it was David Eddy back in the 80s who said that the complexity of modern medicine has exceeded the unaided expert mind. And that was in the 80s. And we think about the amount of data that we have available to us now, that complexity has only grown. And so I'll pass it to Ron to talk a little bit about sort of how does this idea of complexity then apply to AI adoption?
Thanks, Margaret. This is just an example of how this complexity actually manifests in something we deal with all the time in the hospital, like administering medications. So as a physician, I may think, oh, well, if I want to improve how we administer medications, well, like, I definitely want to make sure I don't make errors, right? Well, why don't I build a machine learning model to predict medication errors, or predict or tell me what to order for a certain patient? Like, that might end up being an AI project as we think about it now. But if we take a step back and think about medication administration is not just this one task, but actually something that exists within a complex system that has structures. So you can see the physical structures as well as organizational structures involved in medications, the actual processes, and then the patterns that emerge from the structures and processes in a way that's quite complex. You start to quickly realize, well, maybe just developing a machine learning model to tell me what medication to order may not necessarily actually help us solve the problem. So that's why we do advocate, we step back, think about the system first before you even think about the machine learning, or even you need machine learning in the first place. Next slide. This is a piece that I had written with Steve Ash and Nigam Shah, both of them, I'm sure people you know really well here. And this is kind of our approach to thinking about how do we actually take a step back, and how do we develop what we call a delivery science for AI, where we not just think about the model, but we have to broaden and deepen our thinking around how the models fit into the complexities of healthcare delivery. Next slide. And something that comes from this is this idea that, we should move beyond thinking about AI as just the machine learning model. So this is where, they're not, I would say they don't equate with each other. There is a divergence. We think of AI as the machine learning model, yes, which is an important component, but it really is about how do we develop these intelligent care delivery systems with new structures, new processes, and potentially new patterns that are made possible by machine learning models that are performing prediction and classification tasks. Next slide. And to do this, we realize that it involves a lot of people, a lot of disciplines, not just machine learning, data science, not just clinicians, but it's really an entire stack of capabilities that we actually have a lot here. So in fact, I would say we have many experts, if not world experts here at Stanford in each of these stacks. And this is how I think about any time we implement or develop some kind of information technology for not even necessarily a health system, but let's say a health system, you have to think about how these stacks relate to each other. So if you're implementing, for example, a machine learning model, the machine learning model really just exists within the analytics stack because you're performing analysis of data. But then to make that happen, you actually have to think about, well, what's the technical infrastructure to enable your database? How is the database communicating with your production database, where you have Epic and your EHR, right? I mean, are you representing data using FHIR? Are you representing it using OMOP? And then finally, after you figure that out, you have to think about, well, what's the outcome you're predicting? Is it clinically relevant? What's the software interface you're using to make sure that it actually enables the workflows and teams that you want to improve? And then finally, how does it fit into your organizational and business strategy? And does it align with the changes in legislation and policy and regulations by the FDA and HHS that are existing? So all of these things are actually happening at the same time. And when we think about AI, we have to think about how do we have these stacks talk to each other and work together in order to create these intelligent systems. Next slide.
So then how does this sort of manifest? So what does this look like then when you're sort of embarking on a project and sort of looking to create a system that is enabled by AI perhaps? And really, we would argue that that's not where you should start. And so how do we sort of shift this paradigm? And our thought is that it starts with leveraging existing proven methods for complex problem solving and implementation. So quality improvement, starting with the problem, not coming at it with an assumed solution. So that is not only the clinical team, but also the technical team. Human factors engineering, looking at the system as a whole, the people, processes, technology, and making sure your lens is that broad, because you're now adding and playing with the technology aspect and the tools aspect of the entire system. Using quality by design concepts to make sure that you're looking at designing the features and functionality and processes that meet the needs of the system. Design thinking to connect with how people are feeling as they're interacting with the tool. Implementation science then to take a holistic view on how well was this implemented and ultimately what was the impact holistically on the system. And then secondly, one of the things that we've talked a lot about is where does this idea of prediction and classification sort of fit into the current lenses that we look at for doing improvement work. And our thought is that prediction and classification needs to be added to one of the things that we look at improving a process with. So traditionally we look to reduce waste, minimize variation, minimize handoffs, which is where things can get risky for defects, one-piece flow, pull systems to reduce inventory. I think, for all of us who have done a lot of improvement work, that one of these can enable another, and similarly, prediction can enable waste reduction. So in another way, a pull system can reduce waste. And so it's nice to start thinking about this idea of where does prediction and classification fit in as, I'm thinking about me as when I was purely an improvement professional, adding this to the lens at which I would look at improving a process is sort of opens up your sort of opportunity for what the solution might be. And again, the question is, how can this prediction and classification enable the improvement of the system? We'll talk about the two projects very briefly and then close with just some sort of general discussion comments. Two projects are AI-enabled clinical deterioration prevention and AI-enabled advanced care planning. We'll talk through just briefly what was the problem, the AI task identified, and then how the AI solution is enabling, or how the AI is enabling the solution. For clinical deterioration, the setting for this project is inpatient adjustable acuity units, so non-ICU units. It was identified by a broad team sponsored by, honestly, probably many people on this call and other people involved in this project. So it was a huge team, so I'm speaking on behalf of many, many people. But these incidences of unexpected deterioration events, so RRTs, codes, escalations to the ICU, with some leading to death in the inpatient setting. The idea that we would want to reduce the incidence of these things happening, and then sort of a later term outcome of reducing inpatient mortality. And as we dug in, sort of two things emerged: early signs being missed and signs being identified in some cases but not acted on. And some of the issues that came up as we did a root cause analysis, and this was semi-structured interviews, observations, process mapping sessions, all your sort of classic QI sort of design thinking efforts. Information overload, a lot of stuff, a lot of data in the EHR, and really us picking on just a few as signals perhaps. Continuity issues with shift change, so your idea of a patient's clinical baseline changes. And then no shared definition of severity of illness. That came up several times and actually can cause friction amongst team members and inaction when some early signs are identified. The team then identified their key drivers based off of that root cause analysis. And from that, I won't go through all of them, but actually most of them are workflow related, sort of point to other areas of opportunity that are sort of your general QI track of improvement. But there were a couple that emerged as potentially good AI tasks, which was continuous clinical status monitoring and objective shared mental model for early risk of deterioration detection. I won't get into the details of how we selected the model, but we're using an EPIC out-of-the-box regression algorithm, and that is looking at over 20 indicators in EPIC and producing a flag that effectively means to the end user or the provider, this patient has a 1 in 5 chance of escalation to the ICU, having an RRT or a code event in the next 6 to 18 hours, and that is automatically updating in the background and feeding that information out via a wrenched in column. One thing to mention here is we went through multiple PDSA cycles where this was actually initially, it's a score that is calculated for patients on 0 to 100. And we made that score available to all of the clinicians and said, here's all of your patients. And it was actually quite confusing. In parallel, we were doing a quantitative validation that yielded that the model did not perform well enough to be used in that way anyways. And so there was this very easy way of pivoting towards this other use case that was also useful to the end user. So what we moved to then is AI enabling a shared definition of risk and standardization of workflows, alleviating cognitive burden and friction at the front line. I'll let Ron speak to our advanced care planning project.
Thanks, Margaret. This is another project that we're working on together, and this is something that I'm also working on with Nigam Shah's group, which is the program for AI in healthcare. And this is something that we had started out with thinking about both how do we use a model, but also how do we solve a problem for our health system, which is improving and increasing how we do advanced care planning. Next slide. So similar to how we worked, how we approached the clinical deterioration project, we went back to the key drivers. Forget about AI for a second, forget about the model we happen to have, but how do we actually solve the problem of getting people to do advanced care planning? Is it that they don't know who those patients are? Is it that they don't know how to do it? Is it that they're too busy? Like all sorts of things actually started flowing in, and again, had nothing to do with the machine learning model. And we learned so much. And this is actually a project we took through the CEL program, which was extremely helpful. And going through the key drivers, it turned out that there are many things that prevented us from really achieving our desired state of advanced care planning, one of which was consistent identification of patients who actually need advanced care planning, but it's also making sure that every member of the team had the shared mental model for whether that patient needed advanced care planning. This is also something that we're rolling out inpatient. So we're talking about the hospitalists attending, but also the nurses, the social workers, all these people who are involved in the patient journey as they move from admission to discharge. And it became evident that it was very important for everyone to be on the same page regarding where is this patient, what are their goals, how do we best take care of them? And that was not something that we were able to do right now in the current state. Next slide. So that helped us identify the specific machine learning task. Given that we needed to know who needed advanced care planning, that translated to a surrogate prediction task of predicting who is likely to pass away in the next 12 months, given that that is one of the indications for advanced care planning. So again, I won't go into the details regarding how we built the system, but this is an example of one of the interfaces that we have built out to convey a prediction into something that drives a workflow for inpatient medicine. So we actually set up this automated, slide, go back to the previous slide. Yeah, we set up an automated email that identified a list of patients who the model had predicted to have a relatively high chance of death in the next 12 months. In the same email, it's actually sent, yeah, right, it's very high tech. And the same email is sent to not just the physician, but to everyone on the team, which allows us to achieve that shared mental model for who actually needs advanced care planning. Next slide. And similar to how we're thinking about how AI actually, with the clinical deterioration project, how AI helps, we wanted to step back and just not think about how does the machine learning model affect the next step in the workflow, but how can we achieve that change in the overall work system. So on the left side is kind of like the previous current state system where you have the physicians essentially deciding on their own who needs advanced care planning and just telling people, and then eventually it channels down to the patient. It's kind of a hierarchical approach. But our goal is to actually change that structure using prediction, which allows us to then have everyone be on the same page and everyone know who actually needs advanced care planning, so they could all act together in workflows that previously did not exist. And this is something that we are actually rolling out live and has been quite successful. Next slide. All right, so we're actually done here, and so we have a good amount of time for discussion. So as Margaret had mentioned earlier, this is just, so first of all, thank you so much for having us. And the reason why we're so excited is that this is a new way for us to think about AI in a way that we didn't quite have the space to do before. And it's because we're talking to an audience where we're thinking about improvement purely for the sake of improvement. And if our question overall for Stanford is how do we build our capacity to create AI-enabled systems, we think that the first step is actually just to stop thinking about AI for a second. Stop thinking about machine learning. Think about how do we improve with new systems, and then think about how can AI enable these systems. So this is kind of a shift in thinking that we have developed together over the last year that has been quite interesting and we hope to carry forward. And then the next thing is, how do we expand the types of skill sets that are involved in AI? I think traditionally AI has been thought of as a very technical field, which it is, you know, with computer science, machine learning, data science, et cetera. But I think we've identified that there are actually many other skill sets that are critical to build these systems, improvement science being one of them. And then the third thing is thinking about organization. So thinking back to the stack, the health IT stack that I presented earlier, everything from technical infrastructure all the way up to governance and policy. These are all things that exist right now in the Stanford community, and we realized are all quite critical in creating a finished product. So how can we build the structures and processes to allow these stacks to work in sync and in synergy with each other so that we can do something great? And these are things that I think a lot with Margaret, with Nigam as well through his program in AI and healthcare, as well as Topher Sharp, who I work with as a medical informatics director at Stanford Healthcare. So thank you again, and love to continue the discussion.
Okay, great. Thank you so much, Margaret and Ron. We're all applauding here. You just can't hear the roaring applause that is ongoing. Well, I'm so glad that you've saved some time for discussion, because I've got a long list of questions, and I'm sure others do as well. So
Awesome.
I'd love to have this discussion. And I'll start by saying I love the fact that you guys are straddling these two worlds, because I think it's so critical that we have people who are thinking and developing expertise in both of these areas in order to bring them together. So I'll start off my first question with asking, now that you have spent some time in both worlds, what would you say that experts in AI, what are some of the fundamental misunderstandings or lack of understanding they have about quality improvement that really needs to be brought to bear? And conversely, what about those of us who are in quality improvement? What are some misunderstandings or things that we don't recognize or don't utilize about AI? And then third, what can we do to bridge the gap?
Great question. So Margaret, you want me to take the first part, and then you can take the second part?
Yeah.
All right. Well, I think the first thing is probably just to recognize that we both exist. and we both, we're kind of working towards the same goal. I mean, it sounds a little silly, but because this technology is so complex and requires so much expertise, and you have really people who spend their entire careers working on just one aspect of artificial intelligence or machine learning. So it makes sense that they're not going to be necessarily attending talks like this one, for example, right? So that's actually step one, just recognizing that both are very important. But maybe the second step is to understand that the end goal is not to use AI. The end goal is not even to use quality improvement. The end goal is to solve a problem. And you don't necessarily have to fully understand the science and expertise in the other field. That's why you want to bring those people in. But maybe it's actually figuring out how do you create a shared common language that allows you to communicate back and forth. I think that's actually something we've found, initially quite challenging, but over time, as I'm thinking of how we've improved our workflow and our processes, I think we have been able to develop kind of a language that we can actually take from AI, computer science to quality improvement and back, and then actually allow us to work in parallel to create this product.
Mm-hmm. Yeah, that was going to be one of the first things that I was going to mention, Ron, is I think there is a pretty sort of just a terminology barrier that it sounds like, AI is this sort of unattainable separate activity that's going on. And from a QI lens, you're mostly, there's so much to improve in a system in many ways when you start an improvement project, to sort of add this level of work of trying to figure out how you're going to connect with the right teams to sort of coordinate the integration and the use of a AI model, I think is a big part of it. I've started to sort of talk to some of my colleagues in the improvement space about this and the idea of adding, prediction and classification as something to look for as an enabler of QI and of improvement. And a lot of sort of the response I get is, AI is such an iterative process of learning that it seems like AI gets developed separately, and is it really something that can keep up with the pace of QI, I guess, is one of the things that is something that comes up. And I think one of the things I've learned through these is that it absolutely can. So there's a little bit of a misconception there. But that also, that's part of the issue between, what a technical person looking at QI maybe misunderstands is that it should be a joint sort of development process rather than this work separately. I think, Ron presents his idea of stacks, and that potentially being a key piece of how we start thinking a little bit more broadly about a team associated with an improvement project. And that as an improvement professional, you need to have sort of a working knowledge in the same way that you have working knowledge of pull systems and things like that, all of those things that can enable improvement. And so I think that would be some of the sort of misconception I had.
No, that's helpful. Yeah, I love that. I love this concept of prediction classification. Really, if you think about it, prediction really is one of the key underlining foundational concepts in quality improvement, right? It's moving to this level of sophistication where you can predict what's happening so that you can then control, right? You can then put in implement interventions or countermeasures that will help you get the outcome that you're looking for, right? So it's not that this is something really in many ways fundamentally new. It's just that we have a new tool, a much more powerful tool to be able to apply it, right? Is that fair to say?
Yes, I think that's very fair. Exactly.
Great. Okay, well, we're going to go to the chat, and it looks like Maria has a question. Maria, do you want to go ahead and unmute yourself and ask your question?
Hi, can you hear me?
Yeah, go ahead.
Hi, I thank you for such a great presentation. I think it was really important to kind of bring in the both sides of AI development and the AI implementation together. And I had a question about the project related to the care planning and whether you had a chance to evaluate how people responded to these emails and like what was the adoption or what was the acceptability of receiving an email like this? Did people actually follow through with it? Did they have the conversation? Like what was that like human response to these kinds of information brought by AI?
It's a great question. I can start, Margaret. So I'm so glad you asked. So we just didn't have time to present this, but there actually is a whole perspective study that's going on associated with this project, as well as the project Margaret had presented with clinical deterioration. So we do have that. We have some preliminary data that I'm happy to share with you offline. But actually, this is a good chance to talk about the how would you even conduct such a study? So this is something we're working closely. In this project, we're working with NIGM, Winnie Tuderberg's team, who actually leads the Serious Illness Conversation program, as well as the Evaluation Sciences unit that's led by Steve Ash. And what we've learned is that not only should you evaluate how effective such a program is, as in does it actually increase advanced care planning, which we are looking at, but also we have to look at how well is it implemented. So this is where implementation science comes in. You want to look at the adoption rate, or what are the barriers and facilitators to implementing something that includes a prediction model into a complex work system. Like that's something that actually we don't quite understand how to do yet, which is why it's so critical. And then the third aim is, how do you think about the structure actually changing? So going back to that figure where we presented that conformational change, if you will, of this hierarchical model to something that's more democratized, we are actively looking at, did that actually happen? I mean, this is all qualitative research, but did the work system actually change in that way? And then more interestingly, how did the machine learning enable that change in the structure? So you're really going into, not just does machine learning help, but how does it actually help work systems improve in the way we think they do?
Great, thank you very much. And thank you so much for the question. All right, well, I'm going to keep asking questions because I got a lot of them, but if
I think, David, I see that Jay and Ben Elkins have raised them. Oh, sorry.
Oh, I'm not seeing your hands raised, but let's, okay, why don't we start with Maya, who I saw speak up, and then Jay, and then Ben.
Okay. So Margaret and Ron, thank you for this presentation. I apologize for missing the very beginning, but I was intrigued by your comment, Ron, about the implementation portion being really critical. In some of the work that we've done in developing AI, and really there are multiple steps towards having the product before it's even deployed, we've talked about the implementation piece, we've described it as fidelity. And almost in the way that we look at fidelity of the implementation of a clinical trial intervention, there's the experimental environment outcome and the anticipated benefit. And then when you deploy that in a live environment where there's all the messiness and missing data and enrollment capture and all of that not being identical to what the study environment was like, needing to study that, because when you let AI go, it's running on its own. And so you actually need to study what it looks like when it's on its own. And we've actually borrowed from some of the statistical work for fidelity analysis to really quantify what that translation effectiveness is. So the effectiveness, the intervention in the scientific realm, and then the effectiveness once it's been translated into this new live care version of what you studied. And so I wonder if that's something that you've seen in your work, using some of those methods, because it seems like it's almost glossed over when it's coming from the technical side, but when you're in the clinical environment bringing it in, it's almost essential, it seems.
Mm-hmm.
Absolutely, I can't agree more. So that is actually one of the specific aims we do have for both of our projects, looking at fidelity, reach, adoption, and all those things. But you're actually pointing to something that is also interesting in the sense that, so when we think about fidelity in implementation science, we're actually in some ways assuming that the way we're implementing something is the right way, right? And then we're seeing, are people actually using it, quote unquote, the right way? And I think that's really important for programs that are kind of known to work, you know, like for example, if you have a way to increase our adherence to blood pressure medications, and this is just a tried and true method that we use 20 years and we're implementing it. So of course we want to make sure that there is fidelity. Mm-hmm. With an AI enabled system, I have to admit, we don't actually know what is the right way. I mean, like we're kind of just deploying this in a so-called, I guess you can even think about it as a laboratory, well, living laboratory. And one of the things we're trying to actually see is what does happen. What are the emergent properties that kind of just happen when you design such a system? And yes, we are looking at fidelity. We do have a protocol for what we think people should do, but we're actually equally interested in what people ended up doing. And then one, is that different? But two, maybe what people ended up doing actually is a better way of using AI. And that's very, I think, valuable knowledge.
Yeah, and just two other things to mention on that is we've had a lot of discussion in our projects as to when we are evaluating and understanding impact, are we looking at the entire system? So patients not identified by the model as well as patients that are, or are we just looking at the impact we had on patients that were flagged by the model? And I think where we've landed on both projects is that the lens needs to be broad so that we can understand how that algorithm is functioning in the wild, as you say, which I think is a great way of putting it, because it may not be the same as in a more controlled environment. And I think secondly, going into, you know, my background is QI exclusively, and so sort of delving into the research world a little bit more since I've taken on this role over at the school, is I've found that, you know, before you launch a formal study of whatever that right thing is that you want to study, you know, if it has the effect that you want or not, is having a protected period where you are still iterating and allowing this entire group of people to help you design whatever that protocol is. And so, at least for our clinical deterioration project, we're having a protected period of a couple months where we're actually piloting before we actually build out what the formal protocol would be that we want to test and evaluate formally. And so you can sort of merge the two methods and come up with, you know, something to evaluate formally later on.
Oh, really interesting. Thank you.
Yeah, thank you. Thank you, Maya. Margaret, it sounds almost like an agile process that you're developing now. We're getting into software implementation. That's great. Yeah. Okay, I think we have a question from Jay and then from Ben.
First of all, Ron, Margaret, thank you so much. This was a fascinating talk. Before I ask my question, I was just thinking about one of the earlier questions. I think it was David's questions about, you know, AI is kind of intimidating for a lot of people. And other than just standing afar and saying, wow, that would be cool, but I don't really know how to start doing it in my realm. Maybe what we need to do is, you know, a lot of us feel that way about stats, about statistics, where we can appreciate the value of what a statistician adds to our project. I can't personally tell you what a Kruskal-Wallis or Mann-Whitney U-test is, but I understand how it makes the science that I do more robust. Maybe we have to develop a system where for QI work, there are people like you, Ron, other people who can sort of comment early on about, oh, I understand the problem you're trying to solve. Here's how AI might be able to contribute to that. Without someone having to go and get a formal master's in AI or sort of feel like I am now so well versed. I think we just have to get versed enough to be able to appreciate what the AI experts are contributing to the work. Anyway, onto my question, Margaret, it's about something you said earlier on in the talk. You were mentioning how one of the key things to do is to shift the focus from, I have an AI tool, what problem could I solve with it, to the other way around. You know, here's my problem, how could AI help? And yet you showed that one picture with the balances. where you said there's a glutton of publications on novel AI algorithms and not as many on implementation of existing AI tools. But if we just try to do more of that latter, wouldn't we just be using AI tools to, wouldn't we be in search of problems to apply our tools to?
Yeah, I guess what I wouldn't say is that the body of the algorithms that are available and out there are the ones that should be implemented. I think that wouldn't be what I would say. I think it would be really interesting to understand if we, got, folks that know how to develop algorithms, and we just talked about the problems that really mattered to frontline providers, what algorithms would be built today that aren't currently built at all? And which ones are we not thinking about building, out this sort of capability for, because we just haven't brought the two worlds together in a structured fashion to say, here are some really big problems that we have. I think one example is, we know that documentation is a really big problem. There's a ton of companies out there working on sort of auto documentation, and it's still sort of early stage, but that's actually a really good example of it's a problem that matters a lot to clinicians, and they're building the technology around it. And I hope that there's more literature that comes out of that. But there are others, I think, where they're on the shelf currently right now because when they've been put in front of a clinician, the clinician said, I can't do anything with that. That's not actually that helpful for me. And how unfortunate that all that work was put into building that model when maybe that question could have been asked a lot earlier on. So I think that would be the distinction I'd want to make.
Yeah,
perhaps another scale that we could show is on one side you have problems that have yet to be solved in healthcare, and then on the right side is problems that have been solved with AI. And
Yeah.
we can see a disparity there, right?
Exactly.
Yeah. Well, thank you, Jay. It sounds like I see a lot of parallels with, for example, how we utilize our analytics resources, right?
Mm-hmm.
Where you can easily spend a ton of time and effort building this tool, and then you apply it and realize it doesn't actually do anything, right? So I think I see that there is a greater need for us as quality improvement leaders to work well with whatever our technical counterparts are, whoever they are, whatever the tools are developing, and be better at doing that in a way that actually helps us accomplish our goals. Great. Well, I see that Ben has a question, and then Donnie has a question, and I'm going to have one more question before I let you guys go. So Ben.
Thank you, Ron and Margaret. Ben Elkins with Stanford Children's Quality Improvement. This may be just too tactical, so we can just defer on this. So if I or my team get to a place where we maybe identify that we have a prediction and classification opportunity, who do I talk to? How do I make this happen? You've mentioned partnerships with the SHC, CMIO, but I did not hear mention of Packard.
And are you specifically asking about Packard?
Well, so I'm at Packard, so I guess selfishly I'm curious if we identify opportunities where prediction and classification would be part of the key drivers and countermeasures.
Yeah.
I want to start exploring that. What are my next steps?
Yeah, that's a great question. I mean, you're right in that the processes have not matured yet. I mean, everything is kind of happening at the same time. Specifically for Packard, I mean, I can introduce you to some people who I think would at least help think about how this would work. So Natalie Pagler, I think, is a great person to talk to, who I'm sure you know. Also, Keith Morris is actually a new informatics director at Packard who also works with NIGM, thinks a lot about machine learning, and works with Natalie. So he's also a pediatric hospitalist. So I think he would also be a great person to talk to, and I'm happy to connect you to.
Great, thank you. Donnie.
Good afternoon. I'll try to make this really quick. I know we're running out of time. Thank you so much for the presentation. And I guess I have a very broad question. And it revolves around, so you guys are working to make our systems work much better and for us to allocate resources better. But we exist within a much broader system, which is the American healthcare industry, which is, for better or worse, the most highly regulated and litigious institution and system that exists. How does using AI to help make decisions get impacted or impact that? Like if an AI helps make a decision in terms of who should get palliative care or something, who is now on the hook if there is an argument to be made, the care wasn't right? Does it fall back to the provider, or now is there some faceless AI that's involved in this?
So Ron, I can start with just going on that last piece you talked about, that Donnie. That's actually come up quite a bit, just in a very simple question of, when a model flags a patient, do you tell the patient? Like this idea that there's been this other, team member added that is an AI model. How do you handle that? And where we have always landed is, and this is from discussions with many, many clinicians, from nurses to social work to physicians across the board, is that it's still, none of these AI solutions, at least thus far, I think maybe someone could prove me wrong, but I've not seen one that replaces the sort of clinical determination and judgment of a clinician. It is an input that helps aggregate data to make a recommendation, just like any other team member make a recommendation to the provider or to the nurse. But it is a recommendation that they then have to layer on top of that their experience. And so I wouldn't say that we can now hold the AI accountable as it is an amorphous being, not even, but it would still, and that's something that we've talked a lot about with these projects, is that you must apply your layer of clinical judgment, and we build that into the processes around sort of the actions that come and the system changes that we make. But Ron, anything else you would add?
Yeah, no, this is something that the FDA is definitely thinking about. I mean, because we're just starting to see actually, commercial AI tools entering the market. So some of you may have heard Viz.ai, which is basically artificial intelligence enabled product that helps essentially predict stroke or diagnose stroke. And at this point, Medicare is paying every time someone uses this product, which is actually, now you're starting to think about this as almost a medical device, right? Which does fall under certain jurisdictions and liabilities that don't necessarily come with, oh, I used a prediction model of Epic that helped guide my clinical decision. So I think it probably will end up depending on how the artificial intelligence fits into the work system. So the stuff that we presented, it's clearly very much intertwined with the human system, and ultimately it's the clinician who still makes the decision. So probably, the AI will have less liability and more so the human beings. But as you think about AI as just powering a medical device that's operating somewhat autonomously, like many other medical devices, if they fail, if they harm someone, then the liability will shift. And I think what we're actually going to start seeing more and more of that, especially as you're seeing Medicare insurance companies pay for the use of AI, which is happening right now.
Okay, well, with that, we will wrap up. Margaret, this was outstanding. You've set the bar high. This is great. I love the discussion that ensued as well. I want to highlight a couple of notes in the chat. Sheena pointed out a link to an artificial intelligence in healthcare course here. It's through Coursera here at Stanford, which I've heard really great things about. It's just been launched, so please check that out. And Nalushka wants to connect with you afterwards, I see, and a lot of other great discussion. So again, thank you so much for joining us. Thank you everybody for joining us, and we will let you know about other upcoming speaker seminar topics, and we'd love to hear from you if you have other ideas you'd like to share or you'd like to hear from others. Thank you everyone, have a great day.
Thank you so much.
Thank you.